Who wants to start?
All right, so we're talking about let's make this real interactive. There's only three of us,
Yeah.
and there's a lot more of you, and I'm sure that the wisdom in the audience exceeds the wisdom on the panel collectively. So you don't know about that?
By a lot.
By a lot.
Yeah, by a lot.
Okay. So anyway, the first comment here is about bedside registration and using the hallways in the ED. And so, I think that for all of the things in this section that are sort of the most established and agreed upon, bringing the registration people to the patient's bedside and not having a separate sort of physical space to do that is something that most people agree upon at this point in time. So, how many people do not have bedside registration in their departments? So you should get it. That's the key here. Because even at the LA County USC Medical Center, which is the gold standard
For dysfunction.
in the world, we have it. We actually are having that now. So
We do?
yeah, we actually have people going to the patient to the.
It doesn't work.
Yeah.
It's dysfunctional, but before we go into the individual stuff, I sort of like to frame this as thinking there are reasons we all suffer in our emergency departments that have to do with what goes on in our department. And then there's the big gorilla in the room that we all talk about a lot, which is what's happening in the hospital. Overcrowding, numbers of patients, and exit block. We can't get them upstairs. And I'm sure we've done this panel at many places, and all these things always come up. I'm sure they'll come up again today. But so I think we need to think about what are the things that we can do that are internal to the department versus what are the things where we need to sort of try to get the rest of the hospital, i.e. the administration, to understand that there's a problem that we can't fix, that we need their help fixing. It has to be done outside. So one of the reasons when there are delays has to do with triage and waiting rooms and stuff like that. And, I think to the extent that you have a place which is functional enough that you can get patients in, you shouldn't have a waiting room. You shouldn't even have triage. The only purpose of triage is to put people in order that they need to be seen. That's what a good charge nurse does, right? Is your eyes tells you got to see this one next. Oh, you got to go back to that one. Those I think are, that's only for when the place isn't working already. It's not functioning well and we got people waiting. Of course, most of us, that's where we live all the time. To the extent that we can deal with that, we should make it as convenient as possible by bringing people back as soon as you have a bed, and by not delaying for things like registration. Those should be no-brainers.
Okay, so does anyone want to talk? So I think that's a good way to frame it in terms of internal and external. So obviously bedside registration is pretty internal. Does anyone?
It's not going to solve the big. If the reason that you can't see patients is because all your beds are taken, you can't get people upstairs. How many of you live in a world where that happens fairly frequently? So not all of you yet. We never used to have it. They used to be complaining about this for years, and we would go. Now it happens to us all the time. That you're not going to fix with things like this.
Right. Right.
Okay, go ahead.
We recently had, I don't know all the specifics, but we recently had an outside group under our hospital to analyze the flow of patients. We have hospitalists who admit for a lot of private doctors, and I think, and that report is coming out soon. So in other words, it's not just us pointing the finger in the emergency room. We're going to have an outside group saying, now look at this. This is a big market. I know there are hospitals where once you're admitted, if you're still in the room after 30 minutes, that's a quality issue that study. So I think we're approaching it by having an outside group come
Right.
and give us the results of their study.
We
So I think-
recently had one of these as well, an outside consultant, because sometimes it provides more of an objective report to administration about what the impact is of what's happening, rather than the emergency department complaining about it. It's seen as more of and putting real numbers to it and an actual report. And sometimes that's a good way to approach this problem to make your administration really believe what you're talking about. And we just recently did this as well.
Yeah, so those are good, and because they sometimes will help you get outside support to solve your problems, but sometimes they're because you already have outside support. So maybe one of the things we should do is first start with this issue of hospitals and admissions, because it is something that we're inevitably going to get to, and which I think we should sort of get rid of, take care of first, discuss what we can discuss about it, and then go back to what can we do while we're waiting to get all those good things done? What can we do internally to make it better for our patients and make it better for us and make things solve? So some of you already have a circumstance where you have patients who are admitted and can't get them upstairs. And to me, there are only two things that I can think of that are important to say about that. Some of you know about Peter Viccellio and all the stuff he's done where at his place he convinced the administrator that it's a hospital problem, it's not just the emergency department problem. And they felt it was really important to deal with this, and they understood that it was really dangerous and bad for publicity and bad for the community to have people lying in gurneys in the halls, and that it wasn't any more safe to lie in a hall in an emergency department than to lie in a hall upstairs. So they convinced their hospital administrator that if there are X number of patients lying in a hall in an emergency department, the wards have to start being overcrowded. They have to start taking above their numbers. And once they did that, they were able to wheel people upstairs even when the bed wasn't ready. And guess what happened? The beds got ready.
Right.
It wasn't a problem once they were upstairs. But I think, so, and then we could talk about how can you make that more efficient, and I'm sure we will for a second. How can you make upstairs more efficient? As far as I'm concerned, it's a useless discussion unless you can convince other people that it's their problem. As long as it's the emergency department problem, they're not going to want to deal with this. And if you can convince them, it's easily solved. I think it's mostly easily solvable. So I guess the question for me is, how do you convince the administrators that they should care? Because they're going to hear from more powerful people than us that say, oh, no, we can't do that. The nurses, it's above their quotas. The doctors, oh, no, we can't have my patient lying in the hall, blah, blah, blah. How are you going to convince them?
Well, I'm sorry, this isn't an answer to your question, because I think it's going to, that is hard, one, just to even get them to listen, at least where I work, one of the places I work, the relationship between the emergency department and the physicians is like so bad. But it's better than it used to be, but, you know, I was in the group that got fired, and it was a stuff thing, but, so one of the things that we've tried, and I would like to know how other people deal with this, I think it's sort of a conflict. They'll hurry up and get them out of the emergency department. Sometimes that actually works in our emergency department. And the experiences that we've had just the other day is that, you know, the hospitalists then are so far behind on admitting patients. On a rare occasion, they get out of the emergency department before all their labs are back, et cetera. Then there's this lag time, you know, where they basically don't have a doctor taking care of them. So, of course, the woman with the K that came back with A, coded when she hit the floor, not resuscitatable. Now they're not, you know, that's not going to help with the administrative. You got to get them out fast. They instituted a transport. Supposedly, part of the problem was getting them out there physically. You know, there'd be a bed, but there was nobody to push the cart up there. So they hired a bunch of transporters who have no clue what's going on. So they just took one of my patients out of the hall the other day. There was an ICU patient before I even got to examine them. When they got back, an ICU patient was supposed to go to nurses, so they kind of took the wrong patient. So, you know, another score against us.
Right.
You know, it's like, I think that there's this conflict of hurrying up and getting them out versus the patient care, especially with people patients.
So help her out. Right? You all heard what she said.
You said a lot of different things there.
Yeah, there's a lot of levels.
But I mean, when we talk about, you know, there is a perception out there among some people that what's making the emergency departments, what's bogging them down, is low acuity patients that are abusing the system and they're not really emergencies. There's a very prevalent thinking out there. It's especially prevalent among politicians and among administrators, and it's false. And we actually now have some data to show that it's false. There's some good studies out of Ontario where they've been able to you know, really analyze a lot of volume through emergency departments and show that it isn't necessarily these low acuity patients that are adding time. In fact, it's, as we probably have suspected, it's the access block to the hospital. It's the hospital crowding. So in addition to using our own vernacular and using our own language, for example, we don't let people say emergency department crowding. We don't say that. We make them say hospital crowding. We make sure that we change our language. But really what we're talking about here is winning the attention, favor, and service of our administrators. And that was a question that was posed. How do we get the attention of our administrators? And I think the answer to that is not surprising to you, is money. because they speak the language of business and the language of money. And to some extent,
Pay them off.
so to some extent,
Yeah, exactly.
so at our,
we take a fund.
it depends on where you work. At UCLA, a payment of $10,000 quarterly is sufficient for the no. But seriously, the language of money and the language of business, and to some extent, and there are many leaders within our field that are becoming more savvy with this. We have to learn how to speak that language. So one thing, for example, if you're able to show that it will be more profitable and more cost-effective for your hospital to move people more efficiently through your emergency department, that's something they'll listen to. But they're not necessarily going to read the papers that are, for example, some of the papers I'm referring to are in medical journals. They will more commonly, if you can get them to pay attention to a paper in hospital practice or in an administrator journal, that would probably have more points. And so, to some extent, someone in your group, someone amongst you, has to take some time to learn the language of administration, to learn a little bit about this stuff, and to be able to integrate with them at the highest levels of the hospital. And so that, at some level, has to happen, I think, for you
How
to
do
overcome access block.
How do you show them that that you're telling the truth, that it is in their economic advantage to have the ER work better? You said you have to show them that. Well, is it true?
Well, for every admitted patient that's sitting in X bed for X period of time waiting for their admission upstairs, you have to show that you could have turned over this many patients with an average charge of this, and make some financial impact there.
So Rick actually showed at his little hospital that every patient that they discharged was worth $400 to the hospital. And so not the inpatient who was being admitted, all the patients who were
Right.
just the regular.
The ones that were abusing the system.
And that
Yeah.
and that the longer you had crowding in your place, the more of those patients left without being seen, and you lost them, or went to another hospital. So that there is
Right.
data
There is
that
data.
that even the minor patients are money.
Right. For the suturing, the generating the charges, they're real
Not to mention
charges.
all the bad publicity of we waited and waited and waited, and all the fancy people that don't like waiting. So
Right.
there is this sense of you can let the emergency department get crazy because they have all those non-payers. Yes, we do. We like to complain about them. Some people like to complain about them. But the fact is that they're part of the mix, and our overall mix is that minor patients bring us money. They're business.
Two of the things that we've done that's helped solve some of these problems at our hospital is usually, the ER shift begins at 7 a.m. The administrators don't show up until 9. We have a 9 o'clock, what we call standard meeting, where everybody sits down. 15-minute meeting where the house supervisors come together, the case managers come together, the ER nurse director, the ER physician that's on call, or the ER medical director, whichever one of the two is available. And for 15 minutes, we talk about what's sitting in the ER, what needs to be admitted, what's sitting on each of the floors, how many patients are there, how many rooms are available. Then the case managers go into how many are going to be discharged and what the length of stay of the long-term ones that have been there for 10 days already, and what you do to get them out. So you kind of get a feel coming from the ER, what's going on the floor and what's going out and how many beds are going to be available.
Right.
At the same token, the house supervisors, the nurses on the floor, the directors, and case managers know what's going on in the ER and what they expect to see coming their way as they run down the day.
Right, so-
Some hospitals, not ours in particular, but some of our sister hospitals, have put the ER board with the initials and the problem, et cetera. They put one actually on the floor, so the RN
I like that.
Yeah.
supervisor on the
Right.
floor knows how busy the
like
ER
that.
is, and they can pick out the admissions that they're gonna be getting, they're gonna be seeing already.
So that's
Right.
actually a great point.
Well,
Yeah.
I think, we could come up with a whole bunch of these things that are sort of like that. Somebody says, I've heard it said many times, bring an administrator down to your ER when
Right.
you're busy.
When you got beds in the hallway and how,
They're
you know.
gonna, that's a very dramatic experience. They go like, oh, I didn't know.
Or when their mother's there.
Yeah.
Right.
Right.
Sometimes if they walk in the ER and it's semi-empty, it's like, oh, it's cush. And they walk
Exactly,
But-
exactly.
but,
Has to be
you know,
timed just right.
Somebody also said, they have it at their hospital where the the CEO of the hospital has a camera that looks at the ER waiting room in his office out there all the time. But again, the question I have for you is, not what do you do once you've got their attention, because once you got their attention, the truth is that this is harmful. And they're gonna know that. The question is, how did you get them to agree to this standing meeting? Why did they see it in their interest?
It was actually their idea. The administrator came, we had a UCO that came from Louisiana, who just dealt with Katrina. And when he walked in, he said, well, this is one thing that we did at our hospital. Let's try doing it here.
Well, you're lucky.
And
Yeah. You're lucky.
But again, so
You're
I
lucky.
think the point that Stuart made is the important one. There are many things you can do. So for example, people talk about, what are the blocks? So part of the block is that the hospital doesn't have any beds, but part of the block is that they don't want to, the nurse upstairs doesn't want a new patient, so they delay as much as they can. There's all this stuff about the janitors haven't cleaned the room yet, housekeeping hasn't cleaned it, and the red isn't ready, and we're doing a report, and there are all these artificial things that they do, and there are all sorts of ways to go around them. So I've heard people say that we have something that the moment that the admission is made or that a patient is discharged, housekeeping gets paged. They have to punch a button. They have 20 minutes to get the room clean. When the room is clean, they punch a button. That says the nurse can't say, no, it's not ready, and it makes greases all the wheels. But again, I suspect that all of these solutions, and one other that I think is really useful for another reason we'll get back to in a minute, which is patient gets discharged at whatever time of the day. They don't have to stay in their room for the next 6 hours. How about having a waiting room for them? They're discharged. They don't need to be in a hospital bed. So how about having a waiting room somewhere in the hospital for discharged patients so that you can start cleaning the beds while you're waiting for pharmacy to get their drugs, all that stuff. There are many ways you could make it more efficient, just like a hotel does. But the real key question is somebody's got to want to do that. And I think that's where what Stuart said is really, really important. We need to convince other people that it's not our problem, that it's the hospital's problem. And the best way to do that is that there's really bad publicity and we lose money every time the ER gets to be a bottleneck.
Yeah. And talk JACO language, patient safety type stuff. They understand that too.
There's a gentleman behind you that has a comment for you.
I was just curious, the county system had 300 extra beds, and then they closed King Drew, and now they're only have 40 beds there. How has that impacted getting people out of your ER?
Well, as you know, the situation has been dealt with expertly and deftly by the county, and
For many years.
for many years now. And you're going to see just more of the same in the years to come. But seriously, about MLK, it's impacted all of us in the county. But in terms of where we are in Lincoln Heights, Boyle Heights area, we're far enough away from MLK that it doesn't have the same effect on our ER as it does, for example, at St. Francis Medical Center or Harbor UCLA. They've been more affected by the patients. We are seeing patients that should have been going to MLK coming to our ER. They're being distributed there, but we're not. But I'm thinking that this whole discussion of how the county manages its system it's almost like a whole separate topic from the one that we're on now. I mean, unless you want to have a study in antithesis, if you want to study, how not to do some things, we've done some things remarkably not well. Where's that? Oh, at Drew. Yeah, we got to talk.
So maybe we can wrap up this step and go back to what we could do by ourselves. But I
Right,
do think
sure.
if this is really the gorilla in the room, and if you really want to fix what's the problem for most of our ERs, we have to get other people to recognize that this is not just our problem. As long as it's our problem, you're going to be really happy. And once you get them to recognize it's their problem, I don't think there's any question but that there are all sorts of ways that we can have a more rational system. Let's go back to what we do in our ER itself.
Internal stuff.
But you had a comment first.
Well, yeah, we're talking about kind of the exit door, and the other bottleneck is the entrance.
Correct.
And, now it's left without being seen, Jacob's getting honest about that. How,
Right. So,
address that issue?
sure, so let's go there now. So,
Actually, one of the things about that issue, though, I think the left without being seen, do you see as two different cohorts, like the county hospital system versus the community hospital as two different types of environments, or is that?
I don't think so. I think the literature suggests that this is not patient-specific, that it has to do with long waits, that the long waits have nothing, so the county's worse because there are longer waits, but otherwise it's the same everywhere. and that it's not because the patients who left without being seen didn't need to be there. There's the same percentage of them who turn out to have important disease as just about any other group of patients, and that in fact there is always a subset who left without being seen because they were too sick to wait. So I think this is the problem we all share. UCLA is sort of in between. It's not a county hospital, but we're also a busy place, and we have our own strange mix of patients. So we're a little bit like a private hospital, we're a little bit like a public hospital. Our administrators, just to let you know, we have an old hospital. We are building a new hospital, which opened in 2002, I think.
Yeah, how was it? Was the move-in stressful?
Got moved back to 2003. No, 2004.
We moved into a new hospital in 2000. It was fantastic.
It keeps getting pushed back and back and back and back and back, and then we had a drop-dead date this November, and then they just announced that, well, it's not quite drop-dead.
It's a post-mortem now.
But so someday we'll get into it, but what I wanted to tell you about it is that it's a brand-new hospital, spanking billions of dollars, and in their wisdom, they have made a hospital that is twice the number of ER beds and 3/4 the number of inpatient beds.
Right. Sounds familiar.
So we have the same situation. I guess we are talking about this, but I mean, and that's a huge topic. I mean, we have a hospital, like, we walked around with badges on our lab coat or on our white coats for a year that said 750 plus, which was a number of beds that we thought would be an absolute minimum for the new facility that we're going to move into. And here we find ourselves moving into a facility that's just like Jerry described. You see, I didn't realize that. I didn't know that was the same numbers as year. But so we have an ER that's going to have 130 some odd beds in it, in a hospital that has, I think, in the neighborhood of it's whittling down to something like 300 and something medical surgical beds. It's just ridiculous. Now, we like to poke fun at the county and stuff, but of course we're also part of it, and we've also been working, I've been working hard, and Jen's been working hard to make things better, and there has been progress, and we have had, over the past few years, a more aggressive administration, and we have made progress on certain things like length of stay to try to make the move. So our length of stay was in the 7-day range, and now it's moving down to the 5-day range in terms of inpatients. I don't know if that's going to hold or not, but
they waited 2 days on the
right.
other end to get seen.
That's because they don't count the. Yeah, that was the first question I said. Do you count the ER length of stay in that? But no, I mean, it's very easy to there are a lot of good things that are happening. There's a lot of good people, and obviously it's frustrating. It's a huge system. But let's go back to that.
Comment about the entry block. So one of the things we talked about was registration. If you can get them, do that, and don't make a delay for that. On my sheets, both of my sheets have something about nurse protocols. I'm sure there are
Yes.
others
And on this sheet as
Same
well.
too, here
So
too.
we got a full house.
This is a very, very common thing. So what about that? Should we have standing orders for certain types of patients? So there's the advantages of that are obvious, right? You get things started, you don't have to wait. Somebody's in pain, give them morphine. Don't wait they have to wait outside for. There are reasons where you could think it would be useful. A woman comes in, she's got lower abdominal complaints, get a urine and get a pregnancy test. I mean, those should be no-brainers. But I always suggest that I'm concerned about that as well, because once you start doing this, you start doing more and more and more and more. And I think while there are some things that are obvious, like a urine pregnancy test, there are many others where I think we actually prolong the time by having somebody who's really not able to make the best decisions about which test is needed, starting to do those tests, and ordering a lot more tests than I want to order. And now, oh my God, something comes back indeterminate or positive or whatever, and it doesn't really matter, but I'm stuck with it.
It's a
Now-
BNP, Jerry.
So now,
It's an elevated BNP. What are you going to do about it?
it's a CBC, it's whatever it is. There's so many things. So, or unnecessary X-rays, which happen all the time. So, and I think personally, since I practice my own personal style of practice, I do very few tests. I think it actually ends up making the stay of my patients longer because I have to deal with tests that I wouldn't have gotten. So that's something I'll throw open to you. Do you have really good protocols that are very limited and very specific and point at a specific target and get the right test? Or once you start doing it, is it inevitable that you're going to start giving people, the nurse up at triage is never going to underorder. He's always going to overorder because, that's the natural behavior. and doesn't want to be yelled at for not having gotten the right test. So I think that that's actually, ironically, counter-efficient.
Does anyone want to? I want to put my 2 cents on that. Does anyone want to comment about their triage process?
Both ways.
Right.
If you're looking from an internal standpoint, the nurse who's doing it, some of them actually under order because they didn't want to have the doctor come back. Why the hell did you order this? And having, this time where we're now electronic medical records, they put in the chief complaint and they have a list of only specific tests that they can order. If a patient comes in, traumatic ankle injury, they put in that chief complaint, under their order section, they can only order an ankle and a beta HCG if they need it.
But are they, so A, why do they need a beta HCG for an ankle sprain?
Well, again,
Well,
For the
you're
X-ray,
screening
for
for
the
abuse.
X-ray, yeah.
Screening for abuse. Jerry, come on.
there's specific guidelines where.
And when they order the X-ray, do they have to do an ankle rule?
Well, you know what, by the time you walk in to see the patient, it's nice to already have the X-ray if you wanted it, and if you didn't want it, it's there.
But then,
Or
But-
if you're
Right.
waiting for it to come back from the lab, you can always cancel.
Go ahead.
how about the patient's reaction? Sometimes, they think, I haven't even seen the doctor yet. What are you ordering? I mean, why are you sending, they haven't even touched me yet. I don't even know what you're doing. And so patients don't like it sometimes.
And they can always refuse.
Right.
They can always wait. But
Right.
I'm talking about, the majority of people, it's like, listen, I'm here for my ankle X-ray. I don't
Right.
even want to see the doctor.
Right.
You know,
There are people
there
like
are
that,
people
too.
like that, but there are people like that. But my 2 cents about this is, and we talk about this year after year, is, and the more that and we really are in this business big time. I mean, we're triaging 200,000 patients a year, and we have all kinds of mechanisms. We have nurse practitioners involved in triage. We have physician assistants. We have a separate low acuity area. We've been really in this business, and the more that I experience, the more I come around to thinking that the best way to do this is to have doctors see patients as quickly as possible and to deal with the problem. I think that is the way that it needs to go. I have some data to support that as well, but a lot of it, admittedly, is just my experience of going through this. And you mentioned that ankle thing. I'm a former native of Canada, and the money that we saved by stopping to do ankle X-rays in every single case of ankle sprain was enormous. It was $20 million or so in Canada, and that would have been $200 million in the States. It was a 85% reduction of ankle X-rays that we did when we implemented the OAR, and that still hasn't taken foot here. And if we continue to go to this system where we're, I believe in protocols just as much. I think protocols are wonderful for ensuring for ensuring quality care when you're administering certain processes that need to be done well and systematically and safely, just like in the airline industry. So when you're giving TPA, I think it should be done in a safe manner, and I think there should be effective protocols. But I don't think that implementing protocols to replace our entire profession of what we do, which is to assess and diagnose patients, is going to work. Not quality of care wise, or not cost effectively wise.
Well, should we have a physician in triage? Anyone have a physician in triage?
When you're talking about the physician getting to the patient as soon as possible, your rate limiting step there is going to be the nurse standing between you and the patient.
Well, maybe she doesn't need, or he doesn't need to be standing there.
Absolutely, I agree with that. And you'll know on different shifts of work, you dread when you're working with nurse A and B because they take forever. You know what, you're going to walk in, you're going to interrupt their triage and start over and stuff and see the patient in the triage room because you're not going to wait for them to get back to the bed.
So how many of you work in a
And you have
place?
nurses that are fast.
Yeah.
How many of you work in a place where there are, at least some part of the day, enough doctors where it would be conceivable to do what Stuart just suggested, which is to have a doctor meet the patient right at the front end? For many people, it's not. But I can't agree more strongly. I think that we're abdicating our responsibilities. To some extent, their limited protocols can be useful. I think my experience is that they always get abused, and they end up doing much more than you'd want. And I actually think they lead to harm, whether it's harm by getting unnecessary tests, that even if it doesn't make me inefficient is not good. We shouldn't be doing bad practice. And sometimes is tremendously inefficient. But sometimes limited order sets could be useful if you could actually control them. But I think that's not the real issue. The real issue is there a way? In my place, we're behind all the time, but we're not behind because the doctor is behind. We're behind because we have no beds to see patients. I think the real thing is exactly what Stuart said. Get the doctor to make the decisions quicker. Get the right person to make the decisions rather than saying, well, let's delegate it to somebody who maybe won't do such a bad job. Why shouldn't we do it? Now, if you are going to put a doctor up front, I would suggest that the last thing you want to do is make them a triage doctor. You want to make them a doctor who gets things started on some of the patients, but also gets things finished on a lot of the patients.
That's exactly right.
He doesn't just
That's
say,
exactly right.
okay, it's a sprained ankle, I'll order your x-ray and be done. No, you can finish. It's a sore throat, you don't need blah, 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 send the patient home. Why go through other steps?
We already know from other literature that, I mean, we all know that pass-ons and transfers of care are a major problem, a major risk area. And so why introduce more transfers of care when you don't need to?
It's not like you're talking about either or, like
Right.
you got a triage system where only the nurse is doing it, or you had a distribution doing it. I mean, when we do it, you get the original vitals and everything from the nurse, then they come to talk to us about what they're seeing.
Right.
An ankle, or check an x-ray, and you say, yeah, no, depends on the injury or whatever. Or depending upon how far behind you are, too. I mean,
Right.
if you're several hours behind, by God, yeah, because I'm not going to see you for another hour or so anyway.
Yeah.
So you're suggesting,
You're
I think, a really great permutation for those who can't afford a doctor up front, which is a really good nurse who comes, gets the doctor when something needs to be done. So that if you're going to have someone as your eyes up front, make them your eyes, but don't make them also your brain. Make them your eyes. They say, I got a patient who looks like renal colic. Can you take a quick glance at them and decide if we need morphine, or we need this, or we need a CT, or whatever it is. But you have to have an efficient system, and obviously we're already being interrupted 93 times in our day. That's been well documented. So you got to be careful how you do this. But I would much rather have a nurse say, should I get these 3 tests in a hurry, than have the nurse decide. Personally, I would much rather do that.
There's a comment on here that dovetails onto that, which is just, this is excellent. There's a lot of great things on here, and one of the things is about, the least experienced nursing are doing triage because I guess they draw the short end of the stick, and they don't do it well. And it just runs counter to everything that we know about triage, doesn't it? I mean, when we have a mass casualty, we have the most experienced person, we have the attending out doing the triage. And so, that obviously doesn't work, and we have to put an end to that. We can't have the least experienced nurses doing triage at time. If we have no other way to do it, and we're backed up, and this is a system we've gone to, we can't have the least experienced nurses up front.
The other thing I found is that nurses have a conversation with the patient, which is half an hour long, and I'm walking in the room, and I
Right.
have no idea what they're chatting about. And they thought that they told me everything.
Right.
The only thing worse than what you've just suggested is that they document that entire discussion. You should count your blessings.
They documented what was important,
Right. Right.
or pointed it out to you for a
Well,
particular point.
one of my
Yeah.
favorite, I think nurses are tremendously important. ER nurses can really save your life. They can get you doing the right thing, but they should be doing the job of a nurse. And I love the notion, the modern notion, what's the nursing diagnosis?
Yeah.
Why? And
Or the patient
a
advocate. The
nursing-
patient advocate.
A nursing diagnosis is actually not a diagnosis. You ever read a definition about it? Well, it's not really a diagnosis. It's chest pain is my diagnosis. Well, but what if the nurse documents, you want to get in trouble, what if the nurse documents on the child lethargic? You go in and the kid is bouncing off the
Right.
wall.
And now it's on there.
And now it's on there, and a lethargic child needs a spinal tap. Well, hopefully you do the right thing. You circle it, you say, I saw this child is not lethargic. But to the extent that you don't see a lot of what your nurse writes, which I don't see, it's not going to matter if everything goes well. It only matters if somebody comes, looks at your chart later because, this kid had the flu, but 2 days later it was meningitis. But now on there it says somewhere in there the word lethargic, and you're dead. You are dead. So, it's sort of interesting. Nurses always complain that they have to do menial non-nursing chores, but they don't want to give them up. They don't want to do them personally, but they don't want to have techs instead of nurses because economically it's much better for them if they're in demand. We're the same way. Everybody's the same way. We don't want to do, we'd like to delegate things, but we don't want to have less of us. We want to be important. But I think it's really crazy. Nobody has thought about what's an appropriate ER. Should we have, as far as I'm concerned, I want one really good, experienced nurse to be a charge nurse. In my place, the charge nurse is never a charge nurse. She's the relief nurse for all the other nurses.
Right.
Right,
Who are on
right,
break.
who are on break.
I want a charge nurse who's
And doesn't know what's
looking
going on really with
around.
anybody.
I want to have one or two other nurses who can do nursing tasks. I don't want to have a lot of techs. I don't have that. I have 400 MPH nurses, masters.
That's one thing that we do have at County, though. We have some wonderful, very experienced, wonderful nurses that have provided leadership for us in fairness to our place.
Can I make a couple of other suggestions that I don't see on here, but I think would be really helpful? And, I say would be because I don't have them, but I think we should have them. And I've been staying at windmills for a long time for them. I mentioned before that we should have waiting rooms upstairs for the patient once they're discharged. I think we should also have waiting rooms in our ER that are not for waiting to see the doctor, but are waiting for after you've seen the doctor. When you're discharged, why do you need to take up a room? Why don't you sit somewhere while somebody's doing all this stuff? When you are admitted, most patients don't need to be taking up a room. They could be in a joint room. They could be in a waiting room. Many of them could be on a lounge chair. And even more important, when I was in England for a year on a sabbatical, they did something that I thought was like, when I first saw it, I said, you can't do that. And then I thought, what a brilliant thing. When a patient gets called in to be seen, if they're ambulatory, which is most of our patients, they get called in, they go to a room, the doctor examines them, and then they go back to the waiting room. They don't hold the room for the next month. You're waiting for the test. Why does the patient have to have the room?
Yeah.
We do that
We
too.
do that too.
We do that
We do
too.
that too. We shuffle them back out to
Because
the
we don't have
waiting
enough
room.
room.
Going out to the waiting room, which is really not, maybe we should have a place in our ER with comfortable chairs for all the non-gurney patients after they've been seen, while you're waiting for tests, after you admitted them, after you discharged them. I mean, it seems to me, and you could even make that place comfortable so that they wouldn't be so unhappy. At Cedars-Sinai, right down the block from me, where they have a lot of money, every room has a TV.
Yeah.
When the doctor goes in and says, I'm sorry you've had to wait 4 hours, the person says, shh, shh.
It's American Idol.
It's not just,
Yeah.
not just a TV. In my place, we can't have pillows for the patients
Yeah.
because the pillows walk. Well, you know what? Pillows aren't that expensive. Let's have pillows. How about magazines?
Yeah,
In
free
the waiting
newspapers.
room, there's a 1943 Better Homes and Gardens. That's it.
Right.
Why don't we have it, make it so that while people are waiting, it isn't so uncomfortable? And then there's one other last thing I just mentioned. There was a study where they took patients in an emergency department. It's a great study. And they randomized them to a room with just a gurney and a room with a lounge chair. A lounge chair. And guess what? They had a rebellion with it right after they started the study. Shortly thereafter, the patients who were randomized to the gurney rooms said, no way, I want one of those other rooms. The patients who were in the lounge chair, most patients could be in a lounge chair, they didn't mind as much. They underestimated their time of delay. They felt better. Their pain VAS went down without treatment. The gurney patients, they got pissed off. They estimated their time of not being seen as much longer, and their pain went up while they were waiting.
It's actually amazing. What you're saying is actually really ringing with me right now. We put people, they're having the worst day of their life. They're extremely uncomfortable, and we put them in a miserable, uncomfortable environment in the worst possible. We
With the
never
gown
have.
that
Yeah.
doesn't close.
With the gown, yeah, you're right. You're right. I mean, these are
We could make, it wouldn't
These are
cost
good
a lot.
points.
We could make it into a place that's not so bad while
Right.
you're waiting. You could have something to read. You could watch a TV. It's comfortable where you are. You want to sit on a chair? There's a place for your family member to be there. Now when I go into a room, if we're lucky enough that there's one extra chair in the room, the family member's on it. Either I gotta get them to stand up or I stand up. Why don't we have it be reasonably comfortable? It would be so efficient money-wise in terms of all the benefits. And yet Cedars does it. It's great. Very few places do it. But you're sending them home. These are people who are going to be out in the world.
This is the flag that they would raise, and they would be leaving without their instructions, and the biggest one would be the HIPAA. We would have to move them in there and then move them back out to discuss the discharge instructions with them, which could take up time and
we do this. We do this. What Jerry's talking about, and we have a separate, like we have a room that's a discharge room, and they get called into the room, and there's a special person that does discharge. We have utilization review nurses that help get their appointments, and they spend time with them. So they'll call them in from that waiting room, and then at least when they're in that waiting room, they can be with their family, and you know, it's actually a little bit more comfortable. It's, our place is kind of a dump right now, but you know, you can get around that problem. You just need to have a special room, a discharge room.
The HIPAA point's a good one. You can't just give them
Right.
discharge instructions, although HIPAA in a place like mine, no less theirs, is a joke, you know.
Hip not.
We're doing you know, pelvic pain in the hall.
Right.
You know, have you, how many partners do you have? But, no, that's a good point, HIPAA, but the other stuff, they're gonna be contagious, but you're sending them home.
There is another concern that comes up from nursing sometimes, which is that, you know, if they're not actually being discharged until X time, between the time that they go into the waiting room for their discharge and they actually leave, they're still technically in your care. So that if something were bad to happen, who's actually watching them? Are they actually getting vitals still? Like some of those kind of concerns, which is the kind of thing if you have a.
That's why you leave them in the hallway, so
I
we
mean,
can
I
watch
agree.
them.
I agree. I mean, I know, but this is right. This is the thinking, though.
Why
This
don't
is
we
the
just put
thinking,
them
though.
in the doctor's office so we can really
Right,
watch them?
right.
It's the least crowded space.
Right. Yeah. No, I agree. It's just, you know, if you have a holding area for admitted patients, which is something that we do now, we move people over to this kind of holding side where they're waiting for a bed. But you know, you have to have a provider there to kind of watch them and check their vitals and make sure things are okay. And you
We
know.
got a funny place. Anywhere you go in our place, like, you know, you open up a door or a closet and you're like, oh, there's a few patients stored
Right.
in there.
Every-
And then
every nook
you
and
walk around
cranny.
and, you know,
We're watching
we,
them in
we,
the car.
we had a crowding problem, but now we have a dispersion
Yeah.
problem.
Right,
We've
right,
sort of,
right.
we can't even
Yeah,
remember where they all
yeah.
are.
One thing that I guess has helped a little bit in our hospital is that, you know, people always want to know uniforms, so they just put up a little piece of paper and they change the time, the waiting room time, it's hanging on the triage window.
Right. I was going to bring this up,
For all
actually.
to see, and, you know, I don't know specifically with our patients how much it's been, but, you know, I really hope because we haven't been doing it that long.
So-
Like,
Right.
studies say
The time to what the current of average weight is. Right.
Whatever it is, you overestimate it. It's really, really important.
That's important, yeah.
And you change it periodically so that, you know,
You know you can.
you know what Disney does? When you go on those long lines, you go back and forth, they have intermittent entertainment. You see a clown. And in each place you're getting closer, they let you know you're getting closer. So if it says 2 hours, and you look at that sign, and an hour later it still says 2 hours, you don't realize, well, it's not 2 hours for me anymore. It's you. If you're going to do that, you want to make it somehow that it's getting better. It's getting closer. Another month, and you will be next.
Yeah.
My question is, does that work in decreasing the number of people who don't wait to be seen because they see how long they have to wait in the first place?
Right.
Oh, yeah.
Right.
I don't know about that.
That was always the concern that was
Action.
raised for us also, is that it's a negative for people who actually might have chest pain. They're like, oh, but it's 5 hours, I don't want to be seen, and it could be something real, you know, and they misinterpret the time, they misinterpret how they might be triaged, because the fact of the matter is all those times have a little asterisk where, you know, the sicker patients will be seen first, blah 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 blah, but they don't know who we think are the sicker patients among them, so they're turned away from that number, you know, they hate it. So that's why we haven't done it.
When I was in England, they had such a sign at my place, and it said, the current waiting time is 6 hours. And, you know, I went in, the next day was 6 hours, the next day was 6 hours, and it wasn't a busy place, and you know, it wasn't that busy, and nobody waited 6 hours. And now they have a rule that you have to be finished by 4 hours in England.
Have you guys heard about
It's the
this?
law. And so I said, that sign, 6 hours. They said, oh, that's actually from about 1980. No one's changed it.
That was like the
It's
world.
always there.
The world Armageddon clock or something like that. But that thing in England that he said, I don't know if you've heard about that, but that is, talk to a ER doc in England. It's mind blowing. I mean, they're like, it's like 3 hours and 30 minutes, and the you know, the big sister comes along and says, you know, it's time's up, buddy. You know, it's like, well, I just want to get this, you know, this AST or something like that.
They have a rule that the patient, 90-some% of patients have to be discharged, finished from the ER by 4 hours. Now, of course, it's a silly rule. It's like everything else where it's honored in the breach. So they have all these ways of cheating. So if you're there at 3 hours and 45 minutes, what they do is they move you to a different area called the observation area. And now that you're under 4 hours, and you're admitted to the observation area where you could wait for however long it is. The only difference in the observation area and the ER that in the observation area, no one gets observed.
Right,
It's called the Darwin Challenge Room.
right.
And then there are other really bad things about it, which is like, for example, complicated patients. Basically, they never work up complicated patients because
yeah.
it would take too long, so
Yeah.
they admit them in the hospital.
Yeah. And I've heard the house staff, they're complaining about it, saying, you know, you get a really interesting case and you're working it up and time's up, you know, that kind of thing. But it's interesting
But
just to
it
see what
also
other
did
people have done.
some good- I think it mostly, I was there when they instituted this rule, and I think it was mostly baloney. But there were a couple of good things, and the most important good thing was it got all of them, not just the ER, but upstairs as well, aware of the importance of trying to be efficient.
We have those rules, and I mean, every month we go over and door to doctor, you know, X number of patients, we see 30 minutes, and got out of, and our average length of stay in the ED and all that stuff is being tracked, and we're doing leads, we're trying to get it down to 160 minutes, even though of our group, we retract the very fastest physicians, average length of stay was 160, everybody else is longer, and that was supposed to be our goal time. You know, I mean, so we had, it's like that, we have the rules. I mean, I think it helps you focus on things and.
But there are real reasons why people wait. And part of it is when the culture is it's okay to wait. But I think most of us are way past that now, so we have to really deal with these problems. I do think there are ways, I think from where I work, you know, when I have 14 of my 29 beds with ICU patients who have been there for 2 days, it makes it really hard for me to take care of my patients. And we often have where the waiting room is full, and, you know, we're not like where they are, where it's so endemic that we, you know, it's sort of business. For us, I get really upset when the waiting room is full, and usually when it is, it has nothing to, you know, they say, call in extra doctors. No, we have enough doctors. We've seen all the patients. I do think outside, that's an issue that we really have to solve, exit block. But I also think that there are things we could do to change our mindset from the patient. We're here, you know, we're in charge. The patient is sort of at our mercy, and you know, we'll do for them as we wish, but into a place where, you know, we could make it a lot nicer for our patients. And I think we're all been aware of that in many ways. The whole analgesia movement has something to do with that. But in many ways, it's sort of like, well, you're in an ER, what do you expect? It's not a hotel. Well, yeah, but on the other hand, don't sacrifice care for amenities, but on the other hand, we could do a lot better to make it a much more friendly place.
I think there's a large part of physicians, ER physicians, that really, you know, forcing patients to take care of patients. You know what? The lab issues are the lab issues. The X-rays issues are X-rays issues. Administration issues and holding issues and stuff on the floor is their issues. And we don't actually have the time or want to take time out of our own personal lives to say, okay, you know what? Let's look at tracking the times for X-ray. We know X-ray takes long, especially when Tech A and B is on. So now we need to specifically write that down and show, and then go to administration, or go to the department director of X-ray, or wherever, to find out what the problem is, and try and improve it. And half of it is our fault because, you know what, we don't have the time to actually go in and make us think about it.
Right.
But
And
other
so
physicians make us think about it, you know, lab, you know, you can track the lab time, it's on the printed sheet, when it was drawn, who drew it.
And I think the point you're making, if Diane were here, she would say, if you want to fix this, one of the things you have to do, one of the reasons where a lot of people work in an ER is because you go in, you do your shift, you go home. But if you're really worried about fixing the thing in your hospital, you got to be involved in your hospital. You got to be on committees, you got to know people, and that makes a big difference.
Yeah.
Go ahead.
One statement to comment on the role of the electronic medical records.
Oh, yeah, it's another big
That's a
topic.
big topic.
What is that, electronic medical record? How does that work?
Yeah.
We're trying to adopt that in our report, and we want to do it yet.
So
Yeah.
I could just give you a brief comment what the literature says. The literature says that there are a few places which have managed to integrate EMRs in ways that are really helpful. That cut down on errors, make for increased efficiency, get better billing, do all better communication, that have done pretty well. But they're pretty much limited to 4 systems that are famous, that were the pioneers in this: the Kaiser system, the VA system, the Brigham Hospital in Boston, and the Latter-day Saints Hospital in Utah. And that those places are characterized by, they were all homegrown, They all spent years developing the system. They all were tremendously flexible and made changes when things didn't work. And they all involved buy-in from everybody, right from the start. And they didn't go fast, they went slow, they said, oh, let's see what's happening, and then over time, they got used to it, et cetera. That if you look at systems, that there's no such evidence whatsoever of any of the benefits with commercial systems, or with systems from outside, or with systems where the local community wasn't involved in doing it. And so, and there's a whole other literature that says, we tried it and look at all the unintended terrible consequences. We started making all sorts of errors that we never made before that had to do with the records. It was inefficient, it cost us money, doctors rebelled, other people rebelled, etc. So I think, from my take on what that all means is that there is really something of value in EMRs, but that it's not something you can just graft on. It's something that takes time, effort, really close stuff, buy-in, playing, seeing what happens, etc. And that if you try to force it without going through all those steps, you run really big risks. We got to stop in a minute. One last comment.
So just one comment. I wrote it in for my primary care practice, and it basically says just what you said. I belong to a group of 130 docs. Unfortunately, I couldn't get them in the book. So we're running into the fourth issue when you're talking about what's worse. The IT department thinks that they can design the templates and so forth just with a little bit of input with us without our medical body.
Oh, God.
That, yeah, yeah,
Right.
It is extremely frustrating, and that is the key to the system. When you do this, you have to take it slow. Some physician actually has to have a little bit of programming logic in things when you do build these templates. So
That's exactly, and that when I made that joke about electronic, we haven't had an electronic medical record at county, and now we're obviously having to be, to go into this, and I think we're going about things in just exactly the wrong way. So we're gonna suffer.
We have a,
it is extremely good
We're okay.
if it's done well.
Yeah,
absolutely.
right.
Right.
Well, and that's what I would say. I'm affiliated, we got Permanente, I'm in Seattle, and we all have EMRs, and
It's really good.
yeah, so I don't think you usually go back.
Right, right.
Full medical record is right there.
It's
Yeah.
easy to complain, but there are real advantages
Yeah,
to
sure.
technology. You just have to do it right. And if you don't think and you just sort of say, we're going to start doing this, it's problems.
Yeah, we had
Yeah.
a lot of really nice people around, and it was hard to be angry,
Yeah.
because they're right there being sweet to you, and
Right.
you just kind of want to say damn all the time, and, it's hard to do, actually, there's a lot of people.
And they were helpful, and
They were very helpful, they're right there, ready to deal with your frustration, and I think that's the way to go.
Right.
You have to have that.
Who are those people? Aren't in LA? I don't think we don't have those. We don't have those people here.